Okay, I think we can start. Thank you.
Hello, I'm Rosemary, Communications Officer, and welcome to WHO Africa press briefing. Today we will be touching two very important subjects. The upcoming World Mental Health Day, which will take place on October 10th. And we will also update you on the latest developments of the Ebola outbreak declared in Uganda. First, some housekeeping. You can choose the language you would like to hear, the translation of this press conference, by clicking on the globe on the bottom right of your screen and selecting your language. So let's introduce our panelists. Joining us from Brazzaville in the Republic of Congo, we have Dr. Joseph Kabore, the Director of Program Management at WHO's Regional Office for Africa. Connecting from Kampala, Dr. Jonas Tegen, the WHO representative to Uganda, Professor Pontiano Kalibu, Director of Medical Research, Council of the Uganda Virus Research Institute, and Professor Eugene Kinyanda, Head of the Mental Health Section at the Uganda Virus Research Institute. So a warm welcome to you all. First, we'd like to discuss how mental health challenges affect millions of people in our region. So I turn to Dr. Kabore to explain.
Good morning and good afternoon. Welcome to all the journalists joining this press briefing, where we will provide updates on the Ebola outbreak in Uganda. As you rightly said, we will also focus on a very important issue that affects millions of people in our region. So let me start by telling you, as you said, that next Monday is the World Mental Health Day. This is a very important public health issue across the world. Unfortunately, in Africa, mental health care has not received the attention it deserves. For instance, millions of people needing care do not have access to services, with untreated conditions leading to staggering devastation such as disability, substance abuse, and even suicide. Indeed, in the African region has the highest rate of suicide globally. Around 11 out of 100,000 people die by suicide every year. And this is above the global average of 9 per 100,000 people. It's important to highlight that this situation is partly due to lack of adequate action by government, by policymakers, by communities to address the risk factors that contribute to death by suicide. And underinvestment by African governments is the greatest challenge to adequate mental health services provision. On average, governments allocate less than 50 US cents per capita to mental health. This is very low, below the recommended $2 per person for low-income countries. It's also important to mention that mental health care is generally not included in national health insurance schemes. Among other consequences, this underinvestment translates to grossly inadequate number of qualified mental health professionals. As an example, for every 500,000 people in the African region, there's only one psychiatrist. This is 100 times fewer than what WHO recommends. Let me say it again. For every 500,000 people in the African region, there's only one psychiatrist. And this is 100 times fewer than what WHO recommends. To raise the awareness above the gravity of suicide and step up advocacy about prevention, we are today launching social media campaign to reach 10 million people across the region over the coming weeks. We want to galvanize the support of governments, of policymakers, to increase focus and funding for mental health programming, including suicide prevention efforts. We also want to rally support so that health workers can be equipped to better assist people dealing with suicidal thoughts. We will also provide information so that people grappling with suicidal thoughts know how to seek help and support. We believe that this campaign will equally educate the public so that they can take steps against stigma around suicide, mental health condition, and drug abuse. It is a reality that in many of our societies, suicide remains a taboo, and the stigma associated with it raises a huge barrier to prevention. Yes, suicide is a major public health problem, but a silent epidemic in our region where much of the public health focus is on infectious diseases and outbreaks. It's time for a radical change. Far too many people who need help for mental health condition and to prevent suicide do not receive it. This includes Ebola survivors who need psychosocial support in their journey to full recovery. This is also a reality in the current context of COVID-19 with the increased cases of mental illness. Thank you. Thank you once again to joining us and looking forward to our discussion today. Thank you.
Thank you, Dr. Kabore. Now I would like to turn to Dr. Tegen to explain us how has the outbreak evolved in Uganda since the Ebola outbreak was declared 2 weeks ago. Can you update us?
Thank you, Rose. As you know, on the evening or on the night of the 19th of this last month, or this month rather, we had a positive case identified by the UVRI, and immediately after, on the 20th, the government declared an Ebola outbreak. Since then, we have seen 5 districts being affected with 44 confirmed cases. And in the last 48 hours, we also have 1 additional confirmed case, bringing the total to 44. Have confirmed days of 10. Unfortunately, of the 44 cases confirmed, we have 10 health workers which has been infected, which are positive, of which we have unfortunately lost 4. As you know, when at the beginning of last week, we had about a slow start in contact tracing, which is about 20% or so. But with all partners and most importantly, the government putting all its resources and staff on this issue, now we have almost reached 77% contact tracing. I believe we are proceeding fast in responding to this outbreak. Yes, we started with 3 districts, and since then it has gone into additional 2 districts, but we relate this new district cases to the original Mubende districts, where either a health worker or a positive case have a contact link with the original cases. Yesterday we were hopeful that for one day we had 0, so we might be able to proceed with more zeros. But we have additional 1 case over the night, so now we are looking into how to respond to this. And we thank all partners who were able to come together, ensure that there is Initially, the laboratory was dependent on only sending us samples to UVRI, which is 160 kilometers from the epicenter. But this week, we also deployed, the Ministry of Health deployed a lab on the site, ensuring that the turnaround time of test results being found to less than 24 hours. Now we average about 6 hours. As we speak, I see more and more assets, systems being input, and I am positive that we could control this in reasonably good time. Thank you.
Thank you very much, Dr. Tegen. Now over to Professor Kalibu. Professor Kalibu, please, can you tell us more on the latest genome sequencing results of the Sudan Ebola virus?
Thank you very much. Good morning and good afternoon, wherever you may be. Yes, as you've heard, we have the outbreak. We here at the Uganda Virus Research Institute, working with the partners, especially the USA CDC, have really been providing reference lab work so that we can provide quick results, but we're a bit far from the outbreak. The other thing we've been doing is to sequence the virus. And initially, when we tested, we were able to say this was Ebola Sudan because we have the assays to differentiate. But when we sequenced, we really confirmed that indeed this was Ebola Sudan. The sequence, about 99.6% of the genome, virus genome, which is about 19 kilobase, has been sequenced. It clusters very well with Ebola Sudan and clusters and is nearest to Ebola virus we had here in Uganda in a place called Luwero in May 2021. So it is very close to that strain. There are a few mutations in the virus, but it's very, very close to the earlier virus we had of Ebola Sudan in Luwero. So a person may say, okay, so it's Ebola Sudan. A person may say, where did it come from? Yeah, people say when they hear Ebola Sudan, did it come from Sudan? Not necessarily. Ebola Sudan was first identified in Sudan, but it has spread. Here in Uganda, we have seen previously 4 outbreaks of Ebola Sudan. So we don't know where the virus first came from. And a lot of work is now going on, ecological, anthropological, to find out, to trace where this could have come. It is possible it was within. We don't know really the reservoir. The bats have been identified before, but we don't know where the virus came from. But a lot of work is ongoing to see where this virus could have come from. So it has been sequenced and it is really confirmed as Ebola Sudan. Yeah.
Thank you, Professor Kalibu. Now over to Professor Kinyanda to explain us what are the mental health challenges faced by people who are now affected by this Ebola outbreak?
Thank you very much, Rose, and good morning, good afternoon, journalists. And as Dr. Joseph Kabera has said, an Ebola outbreak like the one we have in Uganda, we have a number of individuals who are vulnerable to developing mental health problems. These include the patients who are admitted to the Ebola treatment units. We also have patients who are in the isolation units. We have the relatives of patients left behind in the community. And we also have the frontline health workers and community health workers. And the reasons why these people are vulnerable for the patients, there's now evidence that the Ebola virus actually invades the central nervous system and may lead to meningoencephalitis or meningitis. Secondly, the manner in which these patients are evacuated from their communities, I mean, it's very psychologically scary. You can imagine a car comes, parks in your homestead, sirens blaring, full headlamps of the ambulance, your property is destroyed because they fear infection. So all this is psychologically traumatizing to the patient. Additionally, when you come to the Ebola treatment unit, usually these people are very sick. There's death all around. The mortality is very high. You have these health workers who are dressed like astronauts in spacesuits. All this is caring for a local community person. Then there's no communication with your relatives for the entire duration you're in the Ebola treatment unit. And at discharge, you face stigma from the community because the community is afraid that you may infect them. Then for the relatives, you have a very sick relative who often is the bread earner in the family. You have stigma. The rest of the community says, oh, this family is stigmatized. You won't be able to go to buy things from the shops. You won't be able to buy things from the market. Then there's the grief. Sometimes your relative dies. And then also there's the ostracization, rejection. As we have seen in the previous outbreak that happened in Individual, there was even accusations of witchcraft. So the community actually wants to expel you out of that community. And for the frontline health workers, there's the fear of infection, there's long working hours, there's the fear for your families. As we have seen, some of the cases have been transmitted through from the health workers to other members of the family. Then there's the death and sickness of colleagues. I mean, as Dr. Jonas has reported, we've heard about 4 health workers who have died. So there's a need to therefore have a psychosocial response to do this, and the Ministry of Health has been able to respond together with partners such as the WHO and UNICEF. There's a need to have mental health workers in the Ebola treatment unit and isolation units. There's a need to have mental health psychosocial workers going out into the community to provide health education, to address misconceptions about Ebola, to screen those who may require psychological interventions. So where are we now? A central coordination mechanism has been established. Field teams right now are out there assessing the needs and providing support. And mental health and psychosocial teams have been established at the Ebola treatment units, isolation units, and there's also ongoing training with support from UNICEF for different mental health and psychosocial teams. But as we have been informed, the area where this is happening is quite broad. There are 5 districts. So there is need for more human resource to support the currently very thin teams on the ground. There's need for transport, and there's need for communication. There's need for also operational research so that we can understand and draw lessons from the current epidemic so that we can then inform future outbreaks. Thank you very much.
Thank you very much, Professor Kinyanda. So thank you to all our panelists also for this overview. So now let's open the floor to questions from journalists. So we also have extra experts to answer your questions on this panel. We have Dr. Florence Bengana, Regional Advisor on Mental, Neurological, and Substance Use. Dr. Tierno Balde, Regional COVID-19 Incident Manager. And Dr. Patrick Otim, Health Emergency Officer, Acute Events Management Unit. So we would like to recall that this is a media briefing. Only questions from journalists will be answered. Please, dear journalists, do use the Q&A function in the Zoom application to ask your question before you are given the floor, and remember to introduce yourself and also the media outlet that you represent. So we're going to jump to our first question. Okay. So just a second. From Nicole Ireland to Dr. Kabore, how concerned is WHO about the international spread of Ebola, and have rich countries learned any lessons from COVID-19 and monkeypox inequities that can be applied there?
Okay, thank you very much for that question. Allow me to answer to the question in French. So let me give just 1 second for those who would like to be on the French channel. Alors, la question porte sur 2 aspects. Le premier, c'est sur la propagation, le risque de propagation de l'épidémie actuelle d'Ebola en Ouganda. Vous savez que l'OMS à une politique de suivi du risque, d'évaluation du risque de propagation des épidémies à travers une politique qu'on appelle le grading. Et cela se fait aux 3 niveaux de l'OMS, au niveau pays, au niveau région et au niveau du siège. Et actuellement, le grade de l'épidémie d'Ebola en Ouganda est au grade 2. Ce que nous avons appris de la COVID-19 et de la variole du singe, c'est que le virus n'a pas de frontières. Le virus n'a pas de frontières et cela est extrêmement important. Ce que nous demandons au pays, c'est le suivi des mesures barrières en conformité avec le règlement sanitaire international. Les épidémies passées, que ce soit Ebola en Afrique de l'Ouest ou celles récentes, comme je l'ai dit, ont démontré que la fermeture des frontières n'est pas la solution idéale. Maintenant, quant aux pays du Nord et les pays qui subissent ces épidémies, COVID-19 nous a démontré que nous avons besoin de plus d'équité, de plus de solidarité. La manière dont le vaccin contre la COVID a été distribué, les équipements, les intrants pour le diagnostic, pour la prise en charge des malades, nous avons plus que jamais appris que l'équité et la solidarité sont extrêmement importants entre pays riches et pays dits pauvres. Je vais parler de la collaboration entre pays du Nord et pays du Sud. Et pour venir à la question proprement dite de Ebola en Ouganda, ce qui est attendu des pays du Nord, c'est surtout le financement dont le pays a besoin. Le pays, l'Ouganda, mais également les pays environnants, les pays qui ont des frontières avec l'Ouganda. Nous attendons également, à travers les leçons apprises, une recherche plus accélérée, plus accentuée pour qu'on puisse avoir un vaccin efficace. Comme vous le savez, la souche actuelle que nous avons, la souche Soudan, n'a pas encore de vaccin. Nous avons 2 candidats vaccins qui sont en test. Et j'imagine que le Dr Tierno Baldé, qui est en ligne, pourra donner plus de précisions là-dessus. Donc, je me répète, nous avons beaucoup appris des épidémies passées. Nous avons besoin de plus de solidarité, de plus d'équité en appui au pays qui a l'épidémie d'Ebola actuellement. Le financement, la recherche pour le vaccin font partie des priorités, tout en mettant l'accent sur les mesures barrières et le respect du règlement sanitaire international. Merci.
Merci beaucoup, Dr Kaboré. Si Paul Adepoju with the Lancet, Paul, can you open your mic and ask your question?
Yeah, thank you very much. So I have 2 questions regarding the gene sequencing insights that was shared. I would like to know whether this provides an insight into the index case and affirmation whether this is a new infection from the wild or the emergence of that is the result of a previous outbreak. The second question that I have has to do with mental health. I would like to know Uganda's mental health practitioner scope. How many, if the number of mental health practitioners that are available in the country would be sufficient enough to meet the urgent mental health needs of this pandemic. Thank you very much.
Thank you very much. Professor Kalibu, if you can answer.
Yeah, I think that's an interesting question because everyone asks, can you find the origin? Where did the virus come from? A very important question. I think you need a multidisciplinary approach to that. The ecological studies that we're talking about, anthropological, and virology can have some role in this. For this case, for instance, the first case that was tested positive was not, we think, may not have been the first case. You need to go back to try to identify what was the index case, and that work is being done through a lot of the surveillance and contacts to find out who are, but unfortunately, many times these earlier cases, they may have passed away without collecting a sample to sequence. But you need to do more sequencing to really find out. It could help you to identify how the transmission has occurred. But what we have done now is not enough really to say this is the origin. It can indicate to us the virus very closely related to an earlier virus that was in Uganda, in the Ruwero district, not closer to other Sudan viruses that were found, and that can give you an indication. However, to find the index, to find the origin, we need to do more work, and a lot of work is going on in the field, looking even in animals, what could be the source, the origin. For now, we're not sure where the reservoir is. The fruit bats have been indicated, but it's not enough. A lot of work has to be done. So more work is being done to really come to the source. But yes, sequencing may help. We are going to do more sequencing, but other areas also going to the ecology and anthropological will be also necessary, needed in order really to determine the origin. Not very easy, but a lot of work is needed and more support and more funding. Over.
Thank you very much, Professor Kalibu. So over to Professor Kinyanda also, if you want to tell a few words about the mental health aspects.
Yes, Uganda has sufficient mental health workers to address the current epidemic. We have more than 50 psychiatrists. We have more than 200 psychiatric clinic officers. We have a few hundred psychiatric nurses. We have psychologists and counselors. So we have sufficient human resource to address this. And the way our mental health services are organized is that we have a national psychiatric referral hospital called Butabika. This is the apex of the psychiatric services. Then we have regional referral hospitals. For example, for the current epidemic, it's around the Mubende Hospital, which is also a regional referral hospital in the Ugandan health system structure. And that hospital has a psychiatrist, it has a team of psychiatric clinic officers, psychiatric nurses. But in order to cover the 5 districts, we shall need to deploy these health workers. We shall have to draw health workers from the other regional hospitals and train them in intervening in the Ebola situation. And of course, we shall require resources to do this because, I mean, there's a need to go out into the community, talk to the relatives, help educate them, dispel these misconceptions, screen, and also provide psychological first aid. So the human resource is there, but we need the facilities, we need the transport, we need the allowances for these health workers to go and be able to function in the 5 districts where this outbreak has taken place. Thank you.
Thank you very much, Professor Kinyanda. So we have a question from Nicholas working with the Wall Street Journal. Is there more clarity about the likely vaccine candidates to be used in Uganda's clinical trial? Dr. Patrick Otim, can you answer that question?
Thank you, Rosemary, for the opportunity, and thanks to Nicholas for the question. So since this outbreak was detected, there has been a lot of engagement on trying to find a candidate vaccine that can be used in this response. So far, from all the engagements that have been done, there are 2 candidate vaccines that are way far ahead in terms of the availability of data on safety and efficacy. And so the first of this vaccine is one that is developed by the Sabin Vaccine Institute with the support from the United States Biomedical Advanced Research and the National Institute of Health in US. It's a single dose vaccine that we hope can be used in this response. The second candidate is a vaccine that is developed by the University of Oxford, Jenner's Institute, which has also been evaluated, and it has some data on efficacy and immunogenicity. However, there are issues in terms of regulatory and ethical approval processes and also some considerations around manufacturing and available doses that can be scaled up to be used for clinical trials. So all these engagements are ongoing, and we hope within the next 3 weeks, we can be able to have more clarity in terms of the doses that are available and the approvals that have been granted by the regulators in Uganda for the commencement of a clinical trial.
Thank you very much, Dr. Otim. Now I have a list of questions for Dr. Balde, coming from Christine from RFI. So Dr. Balde, can we get insights into your probe on 4 cough syrups from India that may be linked to the death of 66 children in the Gambia? Has a link been made? Where is the syrup commercialized? What precautions are you urging countries that sell this syrup to take? And should this syrup be banned? So over to you, Dr. Balde.
Thank you very much, and good morning, and thanks for giving us the opportunity just to mention the current situation here in the Gambia. As you know, I mean, during the past few months, I mean, there have been these increasing notice of acute kidney injuries amongst children here in the Gambia, and then the investigation have been conducted. WHO have been supporting, I mean, the national health authorities here in the Gambia for really investigating the situation and also really responding also to the situation. And at the moment, based on the different laboratories, I mean, that have, conducted some of these tests, we have found some kind of quantity of ethylene glycol and also de-ethylene glycol, you know, into some of these products, I mean, which has been, I mean, administered to some of the children here in the Gambia. And this, as you know, I mean, the ethylene glycol and also the de-ethylene glycol, you know, can be really toxic and can be really fatal, you know, if it has been consumed, especially, you know, by the children. So this is the situation that we are facing at the moment. And currently there are 4 specific drugs, I mean, made of paracetamol, and some of the cough syrups are manufactured by only one manufacturer, which is based in the India, you know, which has been at the moment identified, even though the investigation are continuing. So based on that, an alert was sent globally to all of the different countries. That was sent yesterday by the World Health Organization, you know, to inform the different countries, the different stakeholders, you know, about this information, you know, really to take care of not administrating those drugs, I mean, to the children. So this has gone out, and in the Gambia here, a lot of response action are ongoing, and WHO is really supporting, I mean, the national health authorities. The recalling of these medicine at the community level has started, and but since already some weeks already, I mean, most of these drugs, I mean, produced by the manufacturer has been quarantined, have been really recalled at the household level in different health facilities. So this is currently ongoing. So the response is ongoing, and we are really seeing less now cases. I mean, over the past, 3 weeks, we are seeing less cases. So we are confident about, I think, the hypothesis which is here. And obviously we are urging, I mean, more vigilance, more surveillance, and, you know, to be able, obviously, to stop, I mean, this situation, both here in the Gambia, but also potentially in the other countries in Africa, but also in the world, and including also in India.
Thank you very much, Dr. Balde. Thank you. So we have another question coming from Will Brown with the Telegraph. Over the last week, multiple healthcare workers have privately told that the response to Ebola outbreak has been chaos, or said that it's going to get far worse before it gets better. So this question will go to Dr. Tegen, sorry, Dr. Tegen, and then Professor Kalibu. What is your take on this? Has the response been chaotic?
Well, whenever such deadly disease is announced, of course, there is an apprehension, but I have repeatedly been on the ground, and I could assure you that it's not chaotic. we are seeing that the Ministry of Health doing good coordination, and on the ground, for example, the minister is now currently at this time in Mubende, ensuring that there is good coordination. And the numbers tell us also that it's getting more and more organized. As I said a week ago on Monday, we had 26% contact tracing when we only had about 200 contacts to follow. Currently, we have close to 1,000 contacts to follow, above 800 anyway. And the contact tracing and follow-up of those is above 77%. That tells you that if there were chaos, it was a very transient event, and I believe we have we are more organized, more coordinated now. And the very fact that we do not have additional districts coming up, and the cases are in single digit also tells us that we are, and it's not chaos. That's my assessment. Thank you.
Thank you, Dr. Tegen. And Dr. Kalibo, if you can tell us a little bit more, what's your...
I think Dr. Jonas has clearly explained the situation. And it is not unique when you have an outbreak of this kind. Ebola is feared. It's feared. Initially, there is fear. The public, the health workers, everyone is fearful. And then you have to mobilize the partners, ministry mobilizing all the teams, including the partners. As you know, from time to time, for a long time, for many years, people have been preparing for re-emerging infections. Health and the pathogens are a threat, defense, and all that. So all this has helped us to prepare over a period of time. COVID itself has prepared us. We have a national task force. We have the incident management teams with lab pillars, surveillance pillars, case management pillars. We have strategic committee. We have a scientific committee. All these were quickly mobilized, and they are addressing Ebola. So we are really learning. It's not chaotic, but what happened at the beginning is not unexpected. When an outbreak comes, there's fear, you need to mobilize. So I think things are moving in the right direction. Over.
Thank you very much, Professor Kalibo. So we have another question from Byamukama Aloysius from Radio Mama FM in Uganda. The name Sudan strain seems stigmatizing to the people of Sudan, just the way we saw some stigma against the people of China on COVID-19. Is there any other way to mention this Ebola virus strain without mentioning the word Sudan? I will ask this question to Dr. Patrick Otim.
Thank you, Rose, and thanks for this very important question. I think I would like to outrightly state two facts. One is that these viruses were identified way back in 1976, before the current global good practice on nomenclature or naming of viruses was put in place. So we have since moved away from the practice of naming viruses after the places where they were identified. Unfortunately, for the viruses in this particular genus, we cannot be able to change the names because these names were assigned. So we have the Ebola, even the word Ebola itself is also name of a place. So it's a name of a river in DRC, in Yambuku area. So the names were assigned. What we have been trying to do last year there was the release of the International Classification of Diseases. So the group of diseases that caused by these different species of virus is called the Ebola disease. So sometimes we use the word Ebola disease to refer to all those virus, the disease caused by those viruses. But when we want to be specific, we have to use the specific virus name. Why do we have to do that? Because it has three implications. It has three implications for the testing, because it's not the same reagents and kits that are used for testing. The Ebola Zaire, for instance, that is used for testing the Ebola Sudan. The vaccines that we have, for instance, for the Ebola Zaire do not work against the Ebola Sudan. And then also even some of the monoclonal antibodies and treatments that we have against the Ebola Zaire do not work for Ebola Sudan. So that differentiation is important from that particular angle, but we really agree the fact that if we could be able to reverse, this could have been reversed, but the names have been given and we cannot be able to change. And we always emphasize this, that as Professor had mentioned, that it's not because that the virus is coming from Sudan currently, but it's because that was the first place where it was ever isolated. And we continue, I think, to urge journalists to always put that into context when we are communicating about this particular outbreak. Thank you.
Thank you very much, Dr. Otim. So we have next a question from Liz Mena in Nairobi, working for CGTN. How were the contaminated drugs allowed into the market in the Gambia? This question is for Dr. Balde.
Thank you very much for that good question. Again, as I was saying, I think the contamination of these drugs have been really investigated over the past few weeks here now, and we are quite very, I think it's a relief that we already know, the real causes of this situation. And so the investigation are really continuing, and we know that usually this type of situation happen at the point of manufacturing of these different products, where, for a kind of limited good practices, in manufacturing, they can use some of the products which are not really appropriated, to be used, either by inattention or by several other factors, which can explain the situation. Now in the countries here, this is happening here in the Gambia, and so the investigation are ongoing again to try to see exactly, what has really happened, and also, at different stages, from the manufacturer, to the Gambia here. But I think what is really quite very important here, it's also really to emphasize on the response actions which are ongoing, because in this situation, first of all, understanding the situation was something which was very, very important and very challenging. And so I think the national authorities have done a lot of effort. They have mobilized a lot of effort, a lot of resources, a lot of expertise with the support of partners, the WHO and other partners, for investigating this situation. So this is already a very important outcome. Now from there, as I was saying today, we have teams of the Red Cross, of the volunteers, with the medicine, regulatory agency here in the Gambia, going in the communities, really interacting with the communities, explaining the situation, and then obviously recalling all of these different syrups and encouraging them, to go to the health centers, to limit the automedication, because at the moment we know about those four products, but what can happen, with all the potential products. So it's really important that we try to take this opportunity to standardize the way that we are treating our communities, to build and continue building this trust with our communities, for really trying, to improve, the care of our population, both here in the Gambia, but also learning from here to the other countries of the African region. Thank you, and back to you.
Thank you very much, Dr. Balde. So we go over to Aaron Aino Mugisha's question from Rise News, Uganda. So the Ebola outbreak in Mubende, Uganda comes at a time when people are still battling with socioeconomic impacts of COVID-19. Ebola is spreading. Do experts recommend another lockdown? This question, if Dr. Tegen could answer, and also Professor Kabore, if you could also tell a few words.
I think Lockdown is not recommended in such cases for a number of reasons. One is people, if you do a lockdown, they tend to hide, to go through informal borders. So your chance of having a good contact tracing and getting the contacts to test and care will be minimized. Furthermore, lockdowns have an effect that people would go from the lockdown district to another district. So geographical spread will likely be even more than what you would expect if you lock down, especially when you have porous borders between the districts. So you might ask, what do we do? I think the biggest tool we have is the community engagement and risk communication. If we bring the community with us, which lockdown will do otherwise. If we educate the public, if the public gets engaged in identifying sick people, in contacts, our chance of controlling this outbreak is even far more higher than with a geographical lockdown. On top of that, the geographical lockdown will have economical effects. It will have a social effects, and that would make the response lose the confidence of the community. And as you know, if we are not with the community, we cannot, I'll repeat again, we cannot control this outbreak. Community engagement is our biggest tool, and lockdown will do otherwise. Thank you.
Thank you. Dr. Tegen, over to you, Dr. Kabore.
Yes, I can just support what Jonas just said. WHO doesn't recommend the lockdown at all. That's not the solution. As you rightly said, we need to have the community at the front. But in addition to that, we also need to work on the political will to have this cross-border collaboration at political level, and that's extremely important. I think COVID-19 and Ebola in West Africa, in other countries, are clearly shown that this is not the solution. And I'm happy to let you know that WHO is working currently with the government of Uganda and the Africa CDC to really sit together with not only the government of Uganda, but also neighboring countries to work on that cross-border collaboration, which is extremely useful in such situation. Thank you.
Thank you, Dr. Kabore. So we're taking our next question from Patience Atware with BBC. Is Uganda considering any vaccine trials? If yes, when are they expected to start, and in what populations might they be considered? This question will go to Dr. Tegen, please.
Thank you, Patience. I think this is a good question. As Patrick has already said, there are 2 out of the 8 candidate vaccines. There is safety data on 2 of the vaccines, and one of them is far more advanced than the other in having the data. There is currently Ugandan scientists and international scientists looking into deploying the vaccine from NIH and Sabin Institute. Currently, there are only 100 doses available, and these manufacturers are looking to produce more. It will be a study protocol. What we do not have sufficient data to deploy it in a large, and the supply is not there. Currently, the scientists are agreeing the protocol for the study, and as soon as the protocol is agreed, the import license is received from the National Drug Authority. the scientific committees have approved the protocol. I think the vaccine would be imported into Uganda, hopefully within less than a week, but it might take a week to 2 weeks. What we can promise, or what we know, is as soon as these formalities are addressed, the vaccine will be in the country for 24 to 48 hours later. Currently, the study protocol is looking into the immediate contacts of cases as the potential candidates for this study. Partly it's because we have a small amount of the vaccine, and it's important to establish its efficacy by doing that study. If we succeed, it will be a big breakthrough in having additional tool to control Ebola, this strain of Ebola Sudan. Thank you.
Thank you very much for this answer. Now a question from Okot Lil Romeo with CDN News. How much funds has been injected to treat mental illness in Uganda this year? And yeah, this year, thank you. So over to Professor Kinyanda. And Dr. Bengana, if you can also add a few words. Professor Kinyanda, over to you.
Okay, yeah, thank you very much for that question. I do not have the exact figures, but as Dr. Joseph Kabera has said, we are below the recommended targets that the WHO has set. And also, there's also another problem in that most of the limited money that is coming into mental health services is actually going to the National Psychiatric Referral Hospital, with very little funding going to the primary healthcare services. And that's why we know the bulk of the biggest burden of the mental health problem is. So in addition to having a small budget going to mental health, most of it is going to treat the severe cases of mental illnesses, but we are leaving the bulk of the burden of the mental health problems, which are the common mental health problems: depression, anxiety, alcohol and substance abuse, which is out there in the community. So really there's a need for increased efforts to try and address mental health problems in Africa. And this is a good opportunity that we have journalists on board to carry this message. Thank you.
Thank you very much, Professor Kinyanda. Dr. Bengana, can you also chime in, please?
Yes, very briefly, I will just say that exactly as Professor Kinyanda has said, for most countries in the African region, about 46 US cents are being allocated to mental health. 46 US cents per capita by the governments. That is very, very low. And this is for the regular work that is being done. And then when we have an emergency like this one, we need to think about what more then should be allocated to mental health. So there are two different buckets, I would say. There's the bucket for the regular work, which would ensure that we have all those resources that Professor Kinyanda talked about, that we have health workers at the regional referral hospitals of all cadres that we would need, but then also the healthcare workers going down to the lower levels have the competency to manage mental health problems, which involves training of lower level healthcare workers, which involves budgets. But not only that, but when we have an emergency like this, we need to ensure that mental health and psychosocial services is included and budgeted for as an entity in and of itself for the response. So those are the two areas. And as was mentioned, they are very low, very often the last area that is looked into. Even ensuring that PPEs are provided to the mental health psychosocial support workers, just that simple thing often doesn't happen. So it's good that we have the journalists here and the call is being made for an increase in funding for those two areas, the development work and the humanitarian response work. Thank you very much.
Thank you very much, Dr. Bengana. So from CBC's Nicole, could the mRNA vaccine facility in South Africa make a difference in developing vaccine for multiple Ebola strains? Will there be trials of the Zaire Ebola virus to determine if it could be effective against the Sudan Ebola virus? Over to Dr. Patrick Otim.
Thank you, Rosemary, and thanks to Nicole for those questions. I think the first one, which is very critical, is that having manufacturing capacity within the African region for different vaccines for the highly infectious diseases that we deal with is very, very critical. And the mRNA facility in South Africa was really a welcome development in that direction. Now, in terms of the use of these for vaccines for different strain of Ebola, so the mRNA platform has shown to be a very agile and very effective platform for developing vaccines. So at the moment, the most important thing is that the current candidate vaccines we have, are they compatible with the mRNA platform? That is the first one. The second one then is that the infrastructure that is available in these facilities can be very, very effective in terms of the fill and finish of these vaccines. If the other manufacturers are able, manufacturing the products, and then these facilities can support in the fill and finish to rapidly scale up the number of doses that are available. I think that's an area of collaboration that is critical and is being looked at. So for now, I am not quite sure that they will come in immediately, because usually there's a lot of work that has to be done in terms of both the agreements and the protocols and adaptation of the platforms to be able to participate in the development or production of the vaccine. But that is an area that is worth exploring for both this outbreak, but also for future outbreaks. The second part of the question then, I believe she was asking if there's going to be a clinical trial of the Ervibo vaccine, which was made for the Ebola Zaire species, to see if it is effective against this Sudan Ebola species. I think this has already been looked at by the manufacturers themselves, and early preclinical evaluation already showed that there was no cross protection provided by that particular vaccine against this Sudan Ebola species. So there will then be no benefit in trying to do a clinical trial on this, because it will not add any value. So the focus then now is on these vaccines that Dr. Jonas has explained, which are specifically designed for the Sudan Ebola species, and which there is evidence in terms of the early data that are available that they are able to offer some protection against the Sudan Ebola strain. And then we'll hope to see how effective it is in the context of an outbreak once we have this ring vaccination strategy implemented in Uganda. Thank you.
Thank you, Dr. Otim. So a follow-up question to Professor Kalibu, coming from Paul from the Lancet. Does the sequencing data indicate whether this is an entirely new outbreak or connected to previous outbreaks?
Thank you. Thank you for the question. As we've mentioned that this virus it's a Sudan strain, closely related to an earlier strain that happened in Uganda in 2011. So it means that the viruses are somehow interconnected. Yeah, definitely the other outbreak ended. This is a new outbreak. The biggest question is, where does the virus hide in between the outbreaks? I think that's one of the major scientific questions that we need to address. Where does the virus hide? If it is related, interconnected, then there must be something in the middle between either humans that keeps this virus. And these are the studies that are ongoing: ecological, anthropological, virology, and the rest, to tease this out. We know the fruit bats have been incriminated before, but there must be something else. Yeah, this should be either animals somewhere that have the virus, but they don't get sick, they don't die, that keep the virus. That's a very interesting one. There may be connection between the viruses in the two outbreaks, but the outbreaks ended. There is somewhere where the virus is hiding. Yeah, so that information is needed, and teams are working. And even here in Uganda, not only now, but we have had teams that have been looking in bats, looking in different animals to find out where the virus hides. It's a very, very important question. Over.
Thank you, Professor Kalibu. Then we go back to Dr. Balde with more questions about these pediatric medicines in Gambia. So in particular, so this is a question from Nicola with Wall Street Journal. About the tally of 66 deaths, what period does it cover? In some earlier news reports, Gambian health officials have also said they were looking at the possible role of E. coli. Was that ruled out, or are they still looking at additional factors as well as investigating these medicines? And also, has the WHO already shared the details and photos of labels confirming the manufacturer of the products? The Indian Health Ministry official said it is still waiting for such details. So, Dr. Balde, can you tell us more?
Yeah, thanks for these different questions. And the total death of 66, children happened between July to now. And I think it's important to mention that, as we're saying, this contamination through the ethylene glycol and diethylene glycol is really fatal. And this has not just happened here, in the Gambia, but when we look back, about similar situation which happened in South Africa, in Haiti, in Brazil, in Austria, the case fatality rate of those contamination is really, really high. So that's one situation. Even here, some of the cases were referred from the Gambia to Senegal, but almost all of them also passed away. So it's really quite a very difficult situation, but that contamination is usually very fatal. So it does not really imply a kind of quality of care for sure. We are trying to improve that aspect also in our response, but per definition, the contamination with the ethylene glycol and diethylene glycol, can be really fatal. On the second point here about the investigation and also the involvement of the Escherichia coli, into this situation. This happened in July, where there were a kind of, huge flooding in the Gambia here and also in some part of West Africa. So one of the hypotheses given the clinical presentation of the patient, which started with kind of digestive, features, the clinical digestive, characteristics such as, diarrhea and vomiting and a bit of fever. So that was, one of the hypotheses which were put there, and given also the flooding. But all of these investigation, when we saw, the evolution of the cases, which started with those digestive symptoms and then moved to kidney symptoms. And then after that, even in Senegal, when they were able somehow to fix, and even here in the Gambia, the kidney issue, there we had also a other presentation, of symptoms, affecting the liver, and then after that, even the brain. So all of these evolution just concur, theoretically, to this contamination with the EG and the DEG. So at the moment, again, we are not just looking at that one. We have some proof. We have some, the test which has been done in kind of, reference laboratories, which have determined, these two products. So that's one hypothesis. Is it coming with something else? Those investigations are ongoing, and a very robust study, is planned to be conducted here in the Gambia with the support of the WHO and other partners to conduct a case control study for really trying to go more in depth into the situation while responding, to this situation, because at the end of the day, our ultimate objective is to save life. And this is what is happening currently here in the Gambia, and all of the effort of the national health authorities are going, toward that with the support of the World Health Organization. On the last question regarding the sharing of the pictures of this product, this has been done yesterday on the 5th. The global alert was sent, and I have seen it myself, both in French and also in English, on the product which has been somehow, identified and also indicated. So this information has been shared with the medicine regulatory authority also in India, and also very globally, for really helping people to take the appropriate action for monitoring the situation and also making that surveillance. Thank you, and over.
Thank you, Dr. Balde. So from Pablo Moraga with EFE, there have been 44 confirmed cases of Ebola in Uganda so far. So he wants a confirmation of the number of confirmed cases and also confirmation of the number of deaths. And then we have a question from Claudia with West France. What is the update on the mobile laboratory setup at Mubende, and is the Ugandan health system overburdened? All these questions will go to Dr. Tegen.
Thank you very much. I confirm that the number of cases we have is 44 confirmed cases. We also know that there are probable cases of 20. Let me explain what we mean by probable cases. These are cases which may be related to the positive cases who died before, and the sample has not been taken, so they could not be confirmed. But 44 confirmed cases were there. Of this, 10 has died, and of the 10 who died, 4 are health workers who has been infected before the declaration or before we knew these cases were positive. Maybe Ross, the second part of the question you can repeat.
Yeah, it was a confirmation of the number of cases, confirmed cases, number of deaths, and then about the mobile laboratory setup in Mubende.
Yes.
And yeah, is the Ugandan health system coping well with this epidemic?
Okay, a mobile lab has been established in Mubende. It has the capacity of about 100 tests at a go. So that is why we also see another improvement in the system. As I said, when we started, we have lab results been confirmed 24 hours or a bit more than 24 hours. Because of the Mubende lab, which is fully operational now, we have tested coming within 6 hours or even less, 6 to 8 hours or less. So this is another improvement we see in the system. And I think the figures speak. Uganda is responding well and is responding better every day. Will the system cope? Yes, it will cope, but it will also need the support of our development partners by making available resources so that we can do the we can ensure that the cases are treated, ensure that suspects are tested, suspects are identified, contacts are traced, and as I said, also strengthening the biggest tool we have, the community engagement and the community being aware of this disease. If then sufficient resources are there, yes, we can cope with it. But we should know that Uganda has built tremendous capacity in dealing with outbreaks and has contained and controlled multiple outbreaks, including 2 outbreaks of Ebola crossing across DRC borders, the Marburg outbreak. And also, there has been systems put in place during COVID, which are ensuring that we have a better response capacity. I'm hopeful that Uganda will be one of the places where we can show that the system works. Thank you.
Thank you, Dr. Tegen. So we are coming to an end to this virtual press conference. So I will give you the floor to our main panelists. You have 1 minute each for a final message. We'll start with Professor Kinyanda. 1 minute.
Yes, mental health is a real challenge. We want the message to go out. We need more resources in mental health. We need more training of health workers to recognize these problems. As Dr. Joseph Kabero has ably illustrated, the burden is still very big. So let the message go out and let our policymakers be encouraged to commit more resources to this area. Thank you.
Thank you, Professor Kinyanda. Over to you, Professor Kalibu, 1 minute.
Yes, we've been talking about Ebola Sudan. There's Ebola Zaire, Ebola Bundibugyo. But I think for our public health, it's all Ebola. We need to address it. It's a deadly disease, whatever strain we're talking about, especially these common ones, Zaire and Sudan. There's controversy whether Zaire is more deadly or Sudan. There are controversial data, whether it was more transmissible. There's controversial data. But the key thing, all this is Ebola. We need to address it through the known public health measures that have been communicated. Over. Thank you.
Thank you, Professor Kalibu. Dr. Tegen, a final message?
Thank you. Ebola is a scary disease. So the response in Uganda might have started a bit slow, but a lot of things are put in place. And the Ministry of Health, especially the health workers of Uganda, are doing all what they can. And they will be able to control it. It's for us, the media, the development partners, and other partners to ensure that they have the resources and they have the support to ensure that there is good risk communication, there is good systems to beat this disease. We can do it. Thank you.
Thank you, Dr. Tegen. And finally, last but not least, over to you, Dr. Kaboe, for your final message.
First of all, thank you very much to all the journalists. I think COVID has really shown that there is a close link between NCDs, health systems, and emergencies. And that's the case for mental health. As we rightly said, we found that mental health is extremely important, even during COVID pandemic, in Ebola, etc. So my appeal to journalists is really to contribute in this World Mental Health Day and support WHO and government to really raise awareness about mental health. We say that there is taboo and stigma against suicide. It's not about mental health cases only, but even this stigma sometimes is on, how can I say, professionals. Many medical doctors don't want to be psychiatrists. They prefer becoming a gynecologist or cardiologist, etc. So let's together work to raise awareness so that all these stigma and taboo issues are addressed appropriately. Thank you very much.
Thank you very much, Dr. Kaboe. Thank you to all the journalists for the questions. Thank you for our panelists for all these informations. And we wrap it up here. Thank you for attending. Thank you very much. Have a nice day.
Thank you. Bye-bye.
Thank you.
Thank you very much. Thank you.